So anyway, my goal today is, I'm not a scientist, I'm a parent, but is to give some perspective and some context to what you've heard already. The idea was to do that at the beginning, but it's actually quite nice that you've heard an awful lot already that adds to that. So I'm hoping this will be beneficial. So in 1991, my son was diagnosed with neuroblastoma. And he was a very late relapse. He relapsed at age 20. So, as awful as that was, the fact that he got to grow up, of course, I'm very, very thankful for that. And that's what we want to see all of the children do. Of course, the treatment was very different then, too. So, we hope that threat is diminishing over time. But this quote is on the British Library, and I think it's just so perfect for this parent conference. Knowledge is of two kinds. We know a subject ourselves, or we know where we can find it. So I just think that's a good theme for why we're here. Because we can't have informed consent or make informed decisions if we don't have knowledge and if we don't know what our options are. So that's the goal. One of the things that I wanted to step way back for a moment and talk about cancer, the spectrum of what has been done over, a very, very long time. And it's really quite shocking when you think about, thousands of years ago, tumors were described and there was absolutely nothing you could do about it unless you could cut it out, and it was localized. So metastatic tumors have remained a horrific challenge until the modern times. You finally got radiation therapy and combination chemotherapy in the last century. And this book, by the way, was on the New York Times bestseller list. If you probably have heard of it. If you don't want to read the book, I really encourage you to see the 6-hour documentary that was done based on that book. It came out last spring. It's free on the internet. What's nice is it kind of captures a lot of the work and a lot of the effort that went into cancer treatment. Of course, this is a little U.S.-centric, but this kind of work was going on worldwide. In 1971, the president declared war on cancer. The next 15 years, $12 billion were spent. And so Congress said, okay, how are we doing? And they said, well, mortality is still going up, incidence is still going up, but we've learned a lot. We found out that smoking does have something to do with cancer, and early detection improves survival. Well, the sad thing is that doesn't have anything to do with pediatric cancers. So in the time that has happened since then, you've already heard about the advances in genomics, targeted drugs, new technologies and deliveries, and of course, immunotherapy is a big one. So this is why it's an exciting time. When you talk to researchers who've been doing this for a very, very long time, and they're excited to get up in the morning because it's a new day, that is very encouraging. So that's where we're at. And I know you know that neuroblastoma is rare, but this is interesting to me because of the amount of research that's going on in neuroblastoma. There's over 200 kinds of cancer, and 50%, over 50% of them consist of 4 cancers: breast, lung, bowel or colon cancer, and prostate cancer. So if you look at 1% of all cancers are pediatric cancers, and that consists of probably over a dozen different types of cancers, you have to take that last circle and chop it in 100 pieces. 7 of those represent neuroblastoma. Only half of those are high-risk neuroblastoma. So this is how tiny the incidence is. But look at the interest in neuroblastoma. If you compare the incidence and the number of publications on neuroblastoma, it's really quite shocking. In fact, I was so surprised. I just looked up recently. There's more abstracts in PubMed on neuroblastoma than on breast cancer. There's about 40,000 abstracts in neuroblastoma in PubMed. So that's really quite shocking. So the point is, there's a lot of very bright and talented researchers that are very interested in neuroblastoma. The work continues. So in the late 1800s, there were 2 Germans who noted and described the tumor origin. And then 2 Americans were early in furthering the description of it, and it was named in 1910. And last year, Audrey Evans was honored here at this conference, and because she was the first one in the 70s who came up with a staging system. And then Manfred Schwab, and Dr. Maris mentioned this yesterday, and others ended up figuring out one of the first oncogenes in any cancer, and that happened to be neuroblastoma in the 80s. And since then, MIBG, antibodies, transplant, many other efforts have been made. And then, of course, you've already heard about why data is so important when you have such a rare cancer. If you don't have the information on all the patients, it's very, very difficult to describe it. So the risk group, the staging system, and the response criteria are three major advances for neuroblastoma in order to define these risk groups precisely. There's actually 17 different categories that are grouped into the different risk groups, and it's agreed upon internationally so that now outcomes can be reported accurately. When Dr. Gray just showed you the comparison of the COG antibody and the Cytopen study, we need this kind of information, know what kind of patients are there, otherwise you cannot compare those. So that's how today it looks like there's about half of all neuroblastomas are high risk. And of course, we already know the low and intermediate have very good survival, but the high risk still don't have very good survival. And so in the briefest snapshot, high-risk treatment has become today consisting of, it's one of the most intensely treated cancers, and you already know that. But that's why you have a combination chemotherapy and surgery for induction, consolidation, and then some form of treatment when you're in remission. So that's the idea. So how is research conducted? I thought this was really interesting. When I was looking up the history of clinical trials, the first one on every list was Daniel and his friends saying, hey, we'll just eat vegetables and water for 10 days, see how we look, and let's continue. We can keep on that diet. I thought that was interesting. I don't know if they thought of that as a clinical trial, but it's the first one on the list. And then a surgeon he ran out of boiling oil. That's what they used to pour on wounds in wartime. And he's like, I'm out of boiling oil. I'm going to get egg yolk, turpentine, and rose water. I'm going to put it on the wounds for the soldiers. It's like, wow, they didn't swell and get infected. So that was, again, one of the first observations. And then, of course, the reason why James Lynn is so famous is he's a UK doctor who was the first one who actually did a systematic look at scurvy in sailors. And then in 1943, the Medical Research Council did the first trial for a common cold, and it was the first double-blinded controlled trial. There was another one for streptomycin that is also key. That was only 3 years later. So that's how we got to this day and age of clinical trial. Instead of looking at anecdotal evidences of what happened to this patient, what happened to that. I mean, really, all medical science was case studies before clinical trials came along. But with that came scientific, ethical, and regulatory issues that had to be defined. So this is where the Nuremberg Code ended up, and the Declaration of Helsinki and the Belmont Report. These were spawned by some pretty horrific ways that science supposedly was being done, but that ended up defining how do we protect patients and at the same time have science move forward. Now, as parents of a child with a very deadly disease, we get really frustrated hearing about patient safety. But the truth is you can't have clinical science if patient safety isn't part of it. So this is institutional review boards, this is what they look at in order to approve trials. So, and you've already heard a little bit about this, but stages of research are divided up into three main categories. You have basic science, which is actually performed without the thought of practical ends. It's new information. The translational science is where you take that new information and it's like, can this be applied? Is there something we could do with this? And then the clinical research is where the patient-oriented tested goes on. And an important note is that most agents, as you've heard, are tested in adults first. Now, there are exceptions to that rule, but in fact, yesterday when Dr. Hexey was talking about his trial with the T-cell CAR and adding the PD-1, that was the first time in humans that a T-cell CAR had a PD-1 antibody added to it. So there are exceptions to that rule. So in testing cancer drugs, this type of timeline doesn't apply to all different interventions, but certainly for drugs. You have to do the preclinical work first. Then you do the phase 1, which is looking at dose and toxicity. Phase 2, you're looking at efficacy in a certain tumor type. And then in phase 3, usually it's randomized, as you've heard, and you're looking at improved survival in frontline or newly diagnosed patients, and then that produces a new standard treatment. Now, in a lot of the phase 3 studies you've heard about, this whole process can take 25 years. So it's a very slow and long process for some of the, especially for some of the drugs. Now, trial designs have endpoints, so you have to have a goal, and they're only powered for the primary endpoint. So phase 1 are looking at dose and toxicity. They're powered to do exactly that. So if you're looking at tumor responses, they're not powered to do that. So that's why they have to go on to the next phase in order to really answer the question if there is efficacy. Now, if it's a home run, then nobody questions that. With the CAR-19 cell that were tested in patients with leukemia, that was clearly a home run. When you have a phase 1 study with 90% complete response rates and all of the patients are very, very sick, you don't need statistics to figure out that was good. So in phase 2, you're looking at tumor response, and one of the terms that you'll see in the literature is objective response rate. So they're looking at complete responses combined with partial responses. So it's tumor activity. Sometimes they'll list stable disease, but that's a little trickier to know. It has to do when the patient's evaluated. It's a little harder to compare unless there's long time frames. And then sometimes they look at progression-free survival, which can include stable disease. And then phase 3, you're looking at improved survival, and that's why we see event-free and overall survival curves included in those. But as a patient and a family, we work backwards through this process. We start with phase 3. There wouldn't be phase 3 studies if there was a standard treatment, and that's why you see, at least in the US and in Europe, there's still phase 3s going on. The idea is to improve outcomes for those newly diagnosed patients. In phase 2, a lot of those studies are concentrating on improving the salvage therapy for relapse, but there can be other purposes for those. And then phase 1 is when you introduce a new therapy, and so those are examples. So, as a patient, the goal is to get through the phase 3 successfully and stay in remission. But if you're not responding in the phase 3 study, or the frontline therapy, then you turn refractory, and that's when you have to start looking at other options. Likewise, if you relapse afterwards. So this is where you go stepwise, and this is why you will hear physicians say, you don't usually jump on a phase 1 study right when you first relapse. There are salvage regimens that are very effective. You want to do something that's tried and true before you move into something that's brand new. Nobody knows if it's going to work. So this is the reasoning. Now, when you look for trials for neuroblastoma, there's an awful lot on the NIH listing, and that's not a comprehensive list by any means. But this represents how, since phase 3 studies are so big, there has to be very few of those by nature, and then phase 2 and phase 1 studies, there's quite a few. Again, this isn't comprehensive, there's really actually many more. The phase 1 studies also combine other tumor types a lot of times. So when you already know this, the computer assigns patients on randomization, and the whole purpose is so that those different arms have similar patient groups. You want to look at the age, you want to look at some of the tumor characteristics, you want to make sure those two groups are as similar as they can in order to compare the outcomes of those two groups. Now, there's a type of phase 3 study called the double-blinded, where the patient doesn't know, or the family doesn't know what they're getting, and the doctor doesn't know what they're getting. These are very rarely done in pediatric cancer. But I was really surprised. I just found this study this year, there was a double-blinded study in neuroblastoma. This was conducted the same time frame that Kate Mathey's study was looking at transplant and cis-retinoic acid. This was in Europe. It was in 10 countries. They had 175 patients enrolled. Now, the dosage of this was entirely different from what was going on in the CCG trial at the time. They did a 1/8 of the dose continuously for 4 years. But the patients and the families didn't know, and the doctor didn't know. What were the outcomes? Well, the outcomes didn't look very different. But again, you can't say this doesn't work from this study because of the post-dosing that was done in the CCG study. But what's interesting on this is look how many patients actually finished the 4 years. There were only 9 patients that finished the placebo, and only 7 finished the retinoic acid. So that was interesting. I never realized that a double-blind study had been done. So, and then we've already heard about these randomizations in the Cypin trial, so I'm going to skip over that. This is just a quick snapshot of the major phase 3 studies that have happened. The top is Europe, and the bottom is US. Just since this year, the tandem trial, I won't go through all of these, but the second to the last one on the bottom, the COG 0532, it looks like a lot of the COG doctors are kind of surprised that the tandem results were better, which no one was really expecting or hoping for. So that has affected what's going into the trial design for the next COG. So it's uncertain at this point. So the next COG trial will probably start in about 2 years, and we're not really sure what's going to be included. But all the bolded things were answers to questions in this. But this just shows you how much effort is going on, on both continents to answer these questions for neuroblastoma patients. So there's another type of frontline trial, though, that is not phase 3, and those are pilot trials. That's when they're single arm, they're not randomized, and they're looking at feasibility. They can have enough patients to look at outcomes if they can compare it to historical controls. An example of this one is almost finished, and this is using MIBG with chemotherapy for consolidation or transplant. This one started in 2010 and is about to end. They put 105 patients on it in 23 hospitals in the US. And the question is it feasible? Because MIBG isn't available everywhere. So this information was needed in order to plan a phase 3 with this question in it. So phase 2 studies can be single arm or randomized. Again, the Beacon trial is a beautiful example of a randomized phase 2 because you're looking at efficacy and comparing arms with what would be a better salvage regimen. And then you've heard about some of these other trials yesterday. So phase 1, in the consent form, you will see somewhere these words that the patient may not benefit. And this is very hard for parents. The whole reason why we're looking at trials is hope that the child would benefit. But by definition, phase 1 trials are for dose and toxicity in general. And there are exceptions to the rule now because of the new era of immunotherapy. So clinical trials are being designed a little differently, and there's different expectations for outcomes because of who you're giving them to. You don't design a phase 1 trial for someone who would possibly benefit minimal disease. You wouldn't want wildly progressing disease to go on that. So that times are changing. And so this picture is just to show you why endpoints are important. If phase 1 studies are to look at dose and toxicity, not outcomes. This is why we don't see a lot of survival curves for phase 1 studies. But the NCI put this out, this was in 2008, it's a very discouraging graph, showing 262 pediatric solid tumors that went on trials at the NCI. And so you could see a very, very poor outcome. So this shows just the clinical research process ends up taking you through to regulatory approval. And the example of Unituxin, this took 30 years to get get that far. So it's long and slow. And then you've already heard there's different groups that do this research. And so this is, I wanted to talk about what we really are here for as parents is, thinking about what decisions to make, where can I find the information? In general, you have a treatment path when you're newly diagnosed, but in general, there isn't for refractory and relapse, except for, as Dr. Wheeler mentioned, there is a rationale that is laid out here in the UK. And a lot of places there isn't. So if you are somewhere on this treatment path and you're looking for options, there's going to be different decisions to make at different points. And this is just to show really what life looks like when your child is either refractory or relapse, because there's, it's a twisty, turny road. Okay, so looking at, if you're trying to learn about clinical trials, the real reason why you want to learn about them is where they exist. Then you also want to know about evidence. Every parent wants to know that there's some evidence that this is going to help. And then you're stuck trying to compare apples and oranges. You just absolutely cannot compare what are potential outcomes between new treatments. It's impossible. But this is what we do. We go and look up either preclinical data, which is very, very, very hard to predict what's going to happen in a patient, or you look at other clinical trials. If you go and type in neuroblastoma on PubMed, it's now approaching 40,000 abstracts. About 700 of them are clinical trials. So it shows that that's a really small subgroup of the work that's going on in neuroblastoma. So when you're looking at these statistics, you've seen a lot of statistics, and this is what I wanted to really get to. The interesting thing is that there's a lot more information that can be pulled out than meets the eye. For example, when Dr. Gray was talking about the small number that actually finished the antibody, that reduced the accuracy of that line. And so that's what I want to get to now. You've seen survival curves that have these hatch marks on them, and that's a point where a patient is censored. So what that means, if you have a whole bunch of hatch marks on the left, that means the confidence in what's going on the right-hand side is pretty low, because those patients have not been followed up the entire time that's on that graph, or it's either you're following them, but it's too short of time, or they're lost to follow up. So I want to show you how that affects really the hard evidence of these outcomes. So the sensor data are those hatch marks I showed you. What is left from that reduces down the number at risk. So those are the number of patients that are still being followed, and that affects, the number at risk affects the confidence interval. P-value is a probability that what you see on that graph is due to chance versus the treatment, and then that produces a confidence interval. So if you have a tiny confidence interval, that means it's not due to chance, it is due to the treatment. If you have a huge confidence interval, that means there's some space for randomization there. So this is an example of how that works. We've heard about the antibody trial and how the follow-up it has been brought into question, but the thing is it wasn't powered to look further down the road. So if you look at the first graph, we already knew that it was significant at 2 years. But when you reduce the number down to 4 years, look at the number where the gray arrow is pointing. At 4 years, it dropped from 47 patients to 15 patients, and that's on the antibody arm, and then it from 32 patients down to 10. So you only have 1/3 of the patients being followed here. So that's why, even though on the graph it looks the same to us, it's not significant anymore. And so the 4-year data shows this a little bit more, and you could see all the hatch marks of the patients that aren't followed, where there aren't very many hash marks on the left. So that means that what we're looking at is fairly solid in that we can't tell. And it doesn't mean that the antibody is not effective. And it doesn't mean it is effective. It means we don't know. That's what that means. So when you hear the phrase "is not statistically significant," that doesn't mean that it doesn't work. It just means you don't know. So here's another example one. Professor Berthold showed this one. And this shows survival curves. Look at the numbers on these different decades. I mean, these huge numbers, 356, 497, 1,000, 1,400. So if you see big numbers like that, you think, wow, what's going on with the red line? Why is that dropping down so far? And what are those numbers on the graph? Well, those are the numbers still at risk. So even though on the red line, they started with 1,484 patients, by 5 years, only 370 were followed. That doesn't mean that all the rest died or relapsed. What it means is that that's the number that they had left to follow. The rest of them were lost to follow. So if you look at around 7 years, notice that number drops down to 40. That's why that curve, what's happening where it's dropping below, it's not significant. We don't really know what's going on there. Those numbers have to be big all the way across to know. So then, and this is really the heart of the matter. So when you're seeking options, and many of you in this room have made impossibly hard decisions, there's nothing easy about it, and there is no right way to go about this. And I think the takeaway is really knowing that you're doing your best with the information that you have at the time. And again, looking at how complex our path is, there isn't a right answer. But your family situation, your child, all those considerations have to be taken into account. And looking for, stacking your options, trying to decide how far you're looking, how far you're going, all of those are individual decisions. And I wanted to leave with this very last graph because Professor Berthold helped me understand. This looks like a pretty good survival for relapse. But the thing, and it has 2,200 patients on this graph, but the thing is it includes probably all risk categories. So this would be relapse low risk and relapse intermediate risk, which have a very good survival. So that's going to bump the curve up a little bit. But the point is that there are survivors. And what treatment do those children get? You name it. There's no standard here. But the truth is there are survivors. And so that's the hope going into this, that even though we don't know exactly what the right path is, trusting, your doctor, asking as many questions as you can, finding out, just feeling like your decision is as evidence-based as it can be, is really the best you can do. And I had a conversation with a mom many years ago. Her doctor said to her, look, you are taking all of the decision upon yourself, and that's fine. But if the outcome isn't what you want, then you're going to take all the responsibility. And he felt like he wanted to gently encourage her that this is a shared decision, and you have people to trust that you work with, and those are your doctors. So the fact that there's a shared responsibility helps to ease that that decision making. So.